A very good morning. If you are just joining us, we are heading into a Kickstarter discussion, of course, coming on the backdrop of a tech note where Priscilla Regina Naroga and Dr. Segane were talking malaria over time, especially with regard to treatments. Now, we are going to be delving into the health sector budget and understand how much money is going to control of diseases like malaria and its attendant effects. I'll be joined by two eminent persons who will help us understand the dynamics around it. But let me first give you a preamble, especially on the health budget. For the next financial year, 2023-2024, it's been slashed to 6.5%, up down from 7.2% in the current financial year. According to the Maputo Protocol 2005, each member African country is expected to allocate at least 16% of its total budget to the health sector. Now that means Uganda is not doing a good job on that front. It's one of the member states. Whether we are on track is something that can be debated, especially from different points of view, from the technocrats and other stakeholders. Today is International Malaria Day, and we are going to, of course, be juxtaposing the budget cuts, the resources that go into control of malaria and other diseases, and the amount of money that the health sector gets on a whole. I'm joined by Honorable Dr. Nicholas Kamara, who is the Member of Parliament for Kamali Municipality, as well as Edith Naku, the ED at Uganda Medical Association. I've gotten that right, I hope.
Yep.
Thank you for joining us, Madam and Honorable.
Thank you so much for hosting me, and good morning, viewers.
Yes. Malaria has been an issue for many years, and arguably the statistics indicate it's the leading killer in the country. I would love to first go into the detail of the disease expanse, especially when it comes to Uganda, and this one goes to the official from Uganda Medical Association.
Please come again, the question.
The expanse, the prevalence, so to speak, of malaria within the country. What are the stats, the figures, and where are we when it comes to mapping the areas that are hit most, and what is being done on that particular front from your point of view as an association?
Thank you so much. From the point of view of the Uganda Medical Association, which I head alongside my colleagues in the what we call the National Executive Committee, we are aware that malaria is the leading cause of actually outpatient department attendances in Uganda, with 30% of all OPD attendances being for malaria. That is in everybody. So when it comes to children, it's even higher, because these 30% of attendances that we are getting, most of them are actually children under 5. So when it comes to the under 5s, it even goes higher than 30%. So the prevalence of malaria is very high in Uganda.
That is among children?
That is among all among everybody who comes into the hospital. 30% of it is due to malaria. And for children, it's even higher, because that is a number which contains both adults and children.
Adults and children. Yeah. And how is the health care sector handling this particular issue?
I think malaria is being handled quite well. As you saw, even there was a march, I think on Monday or Sunday, to look at malaria. Malaria is top on the agenda of the health sector in Uganda, and people are doing a lot of work on it. Pediatricians are working right, left, and center, and other doctors, junior doctors, are the same on malaria. So malaria is really on the front of our priorities. Yeah.
Okay, Honorable, when the ED at UMA says malaria is being tackled the best way possible, it means perhaps that the talk about resources being minimal is something that is exaggerated. You are a member of Parliament, and most of these allocations, you know about them. The current allocation, as we've already heard in the preamble, is going to be slashed in the next financial year from 7.2 to a mere 6.5. That is even below half of the 16% that is required of each member state, as the Maputo Protocol puts it in 2005.
Yeah, thank you so much. First of all, I want to correct you.
Oh, thank you.
This is our president is not the ED, is the president of Uganda Medical Association. And which,
my apologies, madam.
And which I'm
so many EDs are coming on the show.
Executive
and which I also fall. So I wanted to make that very clear.
Thank you very much. Much appreciated.
She's a whole president, not just a mere ED.
Mere ED.
So, so I want to appreciate. Actually, I came to talk about the budget mainly. But just to add on what Dr. Naku has said, malaria is quite handled well. Why? First of all, malaria is a very prevalent disease. It is one of the leading killers in Uganda. It is one of the leading causes of morbidity or disease. And of course, definitely when people are sick, they tend to lose a lot of time. You've asked where it is. So far, most of the malaria is in the Usoga region and northern Uganda. And the central region and the western region, definitely there is malaria, but mainly the prevalence is high in western and northern Uganda. And at one time, there is something what is called entomological inoculation rate. It is how many times Say
that again.
Entomological inoculation rate.
Okay.
I'm going to summarize it. It is how many times a mosquito which is infected with malaria bites you per night or per day. And they found out that the highest bites per person in the world were at one time in Uganda, in a place called Apache. So that is
how many were those? How many bites?
Over 15 bites per night of a mosquito which is infected. You know, when it just bites you.
One bite from an infected mosquito is enough to visit malaria.
So when you are measuring how the infectivity of malaria is, you use something called entomological inoculation rate. And that is how many times an infected mosquito bites you over a period of time, usually 24 hours. And at one time it was found to be in Uganda, in a place called Apache, in northern Uganda.
How are we doing right now? Has that gone down?
Well, really, malaria control has been a very big challenge. Just talking about as a doctor, it has been a big challenge because, first of all, it is very hard to spray all the mosquitoes which are infected.
That's right.
Another thing you do is actually to treat, and Italy tried it, is to treat all the people who are infected, all of them, such that when the mosquito bites you, or bites Dr. Naku, and of course it gets the parasites from Dr. Naku, and then it brings the parasites to me. So theoretically, if you treated all Ugandans and they have no malaria, then the mosquito would have nothing to spread.
That is right. Italy achieved that?
No, it didn't. Actually, it didn't, yeah. The only thing, if you read a book called The Conquest of Malaria from 1900 to 1962, an experience of Italy, you find out they used all what we are doing now. They sprayed, they cleared the marshes made in southern Italy.
That's right.
They did massive chemotherapy. I mean, that is by treating everyone. But they couldn't because of obvious reasons. What happened is that malaria was eradicated finally, because of improvement in the status of the well-being of the people.
So that's very important.
If people, because now as we talk, even if we provide mosquito nets, which are treated, some people don't even have where to hang them. People are sleeping down, they have no beds, and you are giving them what? Mosquito nets.
Bed nets.
They don't have beds. Some houses, you find a house which is accommodating 10 people, which is just like a shack. The spraying itself, of course, where are you going to spray? Are you going to spray the bushes? Are you going to spray the water? Are you going to spray? What are you going to do?
In other words, you're saying...
So it is a challenge. Even if you put in a lot of money, now, the most... and now we have even come with residue, indoor spraying.
Indoors residue spraying.
But you cannot do it, because if you wanted to spray all houses in Uganda, how much money would you need? you would need a lot of money. When there are bed nets. So I'm just giving you
yeah, because I'm trying to.
I'm just giving you
just to process it all.
Yes, yes.
And then, of course, for context purposes,
yeah.
Where does that leave us? Should we resign?
No, we cannot give up.
Yeah.
I'm now a politician, and I wanted to just give you an idea of the challenge ahead of us in control of malaria. Of course, Uganda and partners have tried. First of all, there is indoor residual spraying. Then there is provision of bed nets. Definitely there is treatment of people, and also clearing of marshes and water bodies where these mosquitoes breed. This has been tried. Do we need more resources?
Yes.
Definitely we need more resources. And I want to say that we need more resources in health. The financing of Uganda now, as we talk health financing, is 20% government, 40% out of my pocket,
outside, yeah.
40% donors.
Donors.
I just guess that the support of malaria by donors is almost 80%. Whatever you're hearing, bed nets, indoor residual spray, the people who work in malaria context, chemotherapy, most of this is funded by donors. Therefore, government needs even to double its efforts to make sure that we fight proper against malaria.
Very shortly, we shall be requiring you to take us through the dynamics of allocation of funds, especially with regard to the upcoming budget. But first, let me return to the president of UMA. Yeah. When you hear Honorable Dr. Kamara talk about how huge the challenge is in bringing malaria under control, or to even levels that are not destructive to our economic transformation agenda, what you see is something that is not going to be achieved in the short term. Now, within the current or existing framework of interventions, what is not being done right, and how can it be changed?
What is not being done right? Definitely we have high numbers of malaria. Everybody is aware of that. Even it's in our traditional languages, all of us. All our mother tongues have malaria and Yahweh, and you know, and they have explanations for it. So we really need, I think, at the grassroots to tackle people, because people make the difference.
At the grassroots.
At the grassroots, yeah. Because, you know, if you look at HIV and how we tackled it, is we were able to sound the drums, we told the people, we brought them on board, brought the community on board. I think that is the key to malaria. If we don't deal with that, we will never solve malaria. As Dr. Kamara was saying, in Italy they solved malaria by uplifting the standard of the people. So part of uplifting the standard of the people is actually informing the people about what is out there. Our people know. I'll give you a small example. Yesterday, I found a very interesting insect in my garden, which has like sticks on its back, that kind of insect. It's called, in Uganda, it's called kasenyanku.
Kasenyanku.
Yeah, it's a very unique insect. I took a picture.
I have no idea.
You will
what
be
it's
amazed.
Called in English.
Yeah, but you know that there's an insect, when you look at it, it's as if it's carrying things on its back. Now that insect became a very interesting thing, because the lady I was with told me that it prevents convulsions. Of course it doesn't. I mean, okay, they think it prevents convulsions, but scientifically we know convulsions are caused by high fever and all that. So she actually made sure that she took it and kept it. I was looking at it for the scientific interest, entomological, as you say, and she was looking at it for, so people already know about convulsions, they know about malaria, and they are trying to find the solutions. I'm trying to answer your question, which said that what is missing? What is missing is our connection to our people and how they understand things. We are scientists, we are politicians trying to solve scientific problems, health sector funders, but we have not understood how people understand the disease. So if we understand and educate people, sensitize them about malaria, then that friend of mine will look at that insect for the interest of it, but not as a solution to a convulsion.
The problem.
So that is one thing that I think are very severely lacking, and if we don't tackle it, And if we...
So this is down to the ignorance of the population and the tendency...
Not ignorance, I wouldn't say
culture.
ignorance,
Culture.
I would say understanding of
Culture.
disease, how we
Of course,
understand disease.
you can. We would be remiss
Yeah.
to disregard the ability of indigenous cultures to tackle the challenges of the day,
Yes.
especially before the advent of modern medicine. And perhaps that is the reasoning that...
My friend was using.
Yeah.
So we need that. You were asking me what is the gap. We have a huge gap in putting the two together. We have a huge gap in translating our science into the language that people understand. And we did it for HIV. I think we can do it for malaria.
Okay.
We did it for HIV. That's why you see everybody understands HIV. That's why our prevalences went down suddenly. 1990s it was about 30%. Now it's about 6.1% and probably falling. So for malaria and other diseases, we need to apply the same understanding, involve cultural leaders, involve community leaders, religious leaders in tackling the problem. And of course, politicians and scientists coming together. And for me, I think that's a big gap.
How many people are dying daily
Of
because
malaria.
of malaria?
Dr. Kamara,
I wouldn't know. I'm chairman parliamentary forum of
I'm trying to get
diseases.
that specific statistic so that I do not misrepresent or even misinform. People might be alarmed. I don't
want to guess.
I don't want to alarm.
Be guessing.
I don't even want to give an educated one.
Yeah, sure.
I think by the time we finish this,
we should be able to
find
figure
that
out
number.
exactly how
But
many.
it's a very high number.
It's a very high number, and that, of course, is
Under
very-
fives.
Under fives.
It is the leading killer in Uganda. In eastern region, sometimes you find that 70% of the children with fever have malaria. Anyone who come, out of 100 children who come to OPD and they have fever, 70 to 80% of them
That's right.
have 70 to 80 of them have malaria. So it's that high, especially among children and pregnant mothers.
When we look at the map of malaria across the country, you spoke about regions that are most affected.
Yes.
What informs that particular trajectory? Why this region and not the other? Is it geographical? Could it also be a cause of prevalence?
Well, first of all, if you look at areas in Busoga which are mainly affected, those are areas around Lake Choga.
Lake Choga.
Lake Choga. Even in northern Uganda, those are areas around Lake Choga, and of course there are more forests. For example, in northern Uganda, it is less. I can say it is less urbanized, and people tend to stay in rural communities.
Those
natural habitat. Than here in Kampala. Or in Jinja.
But again, it may sound like a contradiction. You come in.
I'm just
within the urban areas. We have a lot of stagnant water. We have a lot of dirty effluent, and then I don't know. That could be a question of how the scientists are looking at it. Would you love to clarify on that?
Yeah, again, I'm delving so much in science.
Let me not
don't worry, because I'm really a scientist.
You're a doctor.
Yes, so, and I'm a consultant.
And we are blessed because you're a doctor and you are on the budget committee.
Yeah, but you see, you go back to the experience of Italy. And malaria is not, the spread of malaria is not going to be about one factor, about only stagnant water.
Okay.
It is also going to be about how quickly you treat a person in the family. Because if I have malaria and I quickly treat myself, it means that the mosquito that bites me is not going to spread malaria in the whole family. That is a factor. The second factor is, if you give me bed nets, do I have the capacity to hang them? The third factor is that I'm in a house. Does that house have nets? Can that house be closed properly so that the mosquitoes don't, as many mosquitoes don't enter? So actually the status of the people in as far as poverty is concerned and housing, and, it means a lot in control of malaria. It means a lot.
So as long as people remain poor, malaria is going to be prevalent.
That is my view.
Yeah, if they are, it is definitely a big factor. But also the other factor is, as Dr. Kamara was saying, the issue of water bodies. Malaria resides in swamps, and stagnant water, as you mentioned. And actually those places in South America and Italy, they are all near marshlands. So marshlands and malaria, actually they used to call mal means bad and aria means air, so they would say bad air, because it's the bad, they used to think it was due to bad air near swamps, but it's actually because of the mosquitoes breeding in the swamps. So the swamps are a big issue with us, but now the other challenge actually goes back also to climate management and climate change. If we are continuing to mess up our marshlands, we will have more stagnancy. More cavera in the swamps, more marshland stagnation, more mosquitoes and more malaria.
Edith Naku, President of the Uganda Medical Association, many thanks for that perspective. We shall be taking a short break, and when we return, this conversation shall continue as we delve straight into the budget cuts and exactly how resources are being channeled into interventions that are aimed at combating the spread of malaria in the country. Do stay with us. In fighting the litany of diseases that the country faces, we have delved into the malaria condition. Why? Because it's the leading killer. And earlier one of our guests was saying the under fives are most affected. What I do have now is an estimate. At least 315 Ugandans die on a daily as a result of malaria. That is a staggering statistic. For many of us to understand it, it's to get a bus and park it there. 315, those would be around 7 buses, and those are the Ugandans that are going as a result of malaria. Now, let's go into the budgeting process and where the money should be and whether it's actually being used the best possible way. Of course, the politics of the day will come in, no doubt about it. The allocation is something that is unavoidable. Let me just begin with Honorable Dr. Nicholas Kamara. Right now, the budget framework paper is already out, and the health sector, we do know that the 7.2% that is the expenditure for this financial year that is due to end is going to be slashed further to 6.5. Like I said in our introduction, that is way below the 60% required of government. I would leave this to you to give us the context. Already we know things are bad, now that there are cuts.
Thank you so much. The context we are in, and you have introduced it very well, is that we are supposed to have 15% of the budget, according to the budget declaration, going to health. The second context, again, which I want to repeat, is about health financing. Health financing is very, very expensive, and definitely no country has ever put the financing of health into the hands of the individual. They cannot afford. They can't manage.
That's right.
And it is potentially incapacitating, and it can actually lead people into poverty, especially those people who are already at the age. Not mentioning, of course, the people already in poverty. So the context in Uganda is that 40% of the financing, of the finances come from donors.
Donor funds,
20% come from government.
The other is out of
40% is from your pocket, me and you. But the pocket we are worried about is not mainly yours and the Dr. Naku and mine. The pocket we are worried is the pocket of the person who is behind, whom the SDGs empower us and tell us that we should not leave anyone behind. That is like 30% of the most poor people in Uganda. So, if you cut the budget at this moment, in these economic times, it means that you are going to throw more people in poverty. It means that, that actually more people are going to die. It is as simple as that. So we come at a situation where we are cutting the budget at this moment, and for us we are very worried. Of course, we're already too worried because there's a lot of money already paid out of pocket. For malaria, when we started with, I don't think it will be affected too much because most of the money comes from donors. For diseases like HIV, still, I think they will be affected, but not so much because HIV. Actually, there is a joke that the only health care that we have, health system that we have in Uganda, is the HIV health system. Because for them, testing is there, screening is there.
Monitoring.
At the lowest level, there is a district HIV focal person. There is every level. There is a way the health system of HIV works, and that's what we would want the system of Uganda to work.
What informs that streamlined infrastructure?
Because of funding.
Funding from the donor.
Yeah, funding. And I'm saying that, for example, the ARVs we have, almost 1 million people on ARVs, almost 95% and more is donor fund.
Okay.
The systems, the infrastructure, the screening, the payment, the streamlining, you know, they have such a word, streamlining, all of that is donors. The money is there.
Yeah.
So it all comes back to resources. Now, I want to talk as a chairman, Parliamentary Forum on Non-Communicable Diseases. I cannot leave without talking about non-communicable diseases. We've seen malaria mainly affects people under 5. But if you go above 30, the mortality of malaria and the infectious diseases actually competes favorably with the mortality of what? Of NCDs. That's diabetes, hypertension, cancer, and heart diseases. It competes. Actually, in some instances, some studies, they found out mortality is higher. If you came to town here, or if you have attended a funeral and you did your own postmortem in the last 1 year, how many people did you hear that they died of malaria? Adults. Usually cancer, diabetes, hypertension, heart diseases, that is killing us. So, but the problem is that the donor is not throwing is throwing no money almost in non-communicable diseases.
Of course, there are
with the government funding, which is almost non-existent also, the people are going to be dying of non-communicable diseases as much. I know. I had to bring in non-communicable disease because it is something that is always forgotten, yet heavily underfunded, and it is responsible for the death of many Ugandans. Now, the other issues we are talking about, again, as I said, the health system that seems to work is the one of HIV. We want that the primary health care be emphasized. We may not start at the village level, and for me, I've suggested, and the health committee, they have suggested that we need VHTs. Yes, that's village health teams, but to me, I think each parish should be having a trained public health nurse.
Public health.
And they used to be there, actually.
The schools are there, but they are closing. People don't find them to be very important.
Okay.
Second thing that people have not really talked about is the cut of the money to PNFPs. PNFPs are private, non-for-profit hospitals. Those who are under Uganda Catholic Medical Bureau, Uganda Protestant Medical Bureau, Uganda Orthodox Medical Bureau, Muslim
religious leaning.
And these people are responsible for 40% of the health system. They also have their own health system in the whole country. They have been given only 1% of the budget. Only 1%. Unfortunately, they are going to cut 80% of their budget this financial year. What is it going to do? Again, it's not going to affect you. It's not going to affect Edith. It's not going to affect me. It's going to affect the person who is health center, which is nearest, is the PNFP. And these are the things, of course, I know she's going to talk about it.
Some kilometers
again,
away.
They have cut the budget of interns. And these are small budgets, by the way. These are small budgets. The PNFPs just take 28 billion per year. With the whole system, government funds them with 28 billion.
Shortly, you'll be telling us where you are muzzled as a legislator in ensuring that these allocations go the right places and how that comes about. But let's come to President of UMA. What is the state of affairs right now when it comes to the health sector, I know personnel is important, and whether personnel is trained or not. We have issues with interns. Just yesterday, some were protesting, saying they are not being deployed. Even when they are deployed, there are no allowances for them. Doctors themselves already haven't become comfortable enough, despite the fact that there was some intervention when it comes to improving their wages. We do not know how far that is. Just take us through where we are right now in financing the health sector with regard to personnel and our ability to be able to administer.
All right, thank you so much. And I'm keeping that what he has just said in my brain because it tickled me, but we'll get back to that. The issue about the health sector or personnel. There is a page in here, I think it was page 1. This is the annual health sector performance report, which is a wonderful report. It says
annual health sector performance report, financial year 2021-2022.
Yeah, and when you look at, I think it was page 141 or 142, they have something about personnel and the ministry, because you've said something very important. What a person, I mean, what is, we know how important personnel are to any working system. If you have a school with all the chalk and paper and you don't have teachers, it is useless. If you have a hospital with all the medicines and with all the theaters and you don't have, it's basically a graveyard. I mean, you're going to just kill people there, because if you take someone who is needing oxygen and there's nobody to help them, they're not going to live. So personnel are key to the system of health. And we, right now, if you look at, I think it was page 142. Anyway, they have a
page 142
where they talk about the strategic objective 2 for the Ministry of Health is to improve personnel. And then, that is their personnel. That's their strategic objective 2. When you look at the performance of last year, you will see that they counted interns. One of the outputs they have is that they released, I think, 1,700 interns, intern doctors last year. That is one of their key outputs, and I think that helped them raise their performance indicator. However, this year, nobody out yet. So we are asking the Ministry of Health, if your strategic objective 2 is health personnel, and you are saying you're not sending out anybody, so what have you done? What are you doing? You're basically, I don't want to answer that question because it may sound rude if I answer it, but it's a logical thing that they should ask themselves. If you've said that putting out interns into the field is one of the key indicators, and you have not done that, and you're not planning to do it, and if you plan that they will walk by chance to those places according to their calling, as they say that we have a calling as medical people to serve, then you're saying that even if you feel called, I will not pay you.
Not pay.
Totally flabbergasting.
Before you go any further than that, just bring us up to speed with the role of the intern in Uganda's medical landscape. Because when they go on strike, we seem to realize that there's a lot that goes on standstill. Yet, by virtue of being interns, they are not yet ready to do the job as they ought to do it.
Oh, thank you.
So we are confused as...
That's a wonderful question. That is a question I've been dreaming of that you would ask me.
All right, there you are.
This is the key. People we do not really, when you hear the word medical intern, you do not really understand what it is. They are not just interns. They are medical doctors who have graduated fully, and now they are working under supervision. That's why they, in fact, in some countries, they call them junior house officers or junior doctors. That's what, but we have a term, we call them medical interns. But they are actually doctors working under supervision for a year. Because you need to work under supervision for a year before we send you out completely on your own, in your back little clinic somewhere where nobody is seeing.
So in other words, the internship period is for the doctor to demonstrate that they are actually capable of doing the job to the supervisors.
It's just actually to refine the doctor. Because they have been in the clinical years for a whole 3 years.
Exactly.
Third year, fourth year, fifth year. So the 6th year is just to refine them.
Yes, and so that's what they do for that 1 year under supervision. And these people, to understand, I think, so that's why you hear people saying, why don't people understand? Once you're thrown onto the ward on day 1, you are in charge.
As an intern.
As an intern, you admit the patients, you put up the blood, you put up the drips, you work. Of course, your seniors will come and look at your work, but you are left to make.
What are the ratios there, intern per patient?
I'm trying to remember like 20 years
If you're
ago.
deployed on the ward and you, from
when
day
you're-
one,
Oh,
you're supposed to take care.
if you go to places which are very busy like Mulago, an intern could see 100 patients
Yes,
per day.
at night. Yeah, yeah. When
It's
you're
24 hours. One.
It's true. When you're on the ward, like in acute care unit,
100.
yes,
Yes.
yeah. Every
Patients.
time people
Yeah.
are in,
You
you are
go in a
looking
business
until you
ward.
finish. Actually, I remember the first night I did my internship many years ago. It's the first trans night I ever had, because I worked from 7 in the morning to 7 in the morning, and my boss found me on the ward, and that is the norm. They work from 18 to 24 hours a day. And they are very busy running around, and they are being, of course, monitored by their seniors to make sure that they don't do anything wrong. And they are very tired, and they have no time to do anything else. They have no time to go and do a side hustle, no time to even sometimes sleep. They need a place to sleep, they need food, and they need a living wage. So that's what a medical intern is, or a junior, what we call a junior house officer. And then there's what they call the senior house officers. These are doctors who have finished school, worked for about 2 or 3 years, then come back to do their specialization. Those are senior house officers. They also do the same. They are actually, them and the interns, they are the ones on the ward running around.
All right, next question. There's a lot of complexity in there. If you have more senior house officers on duty and interns, where are the other doctors, the regular doctors, you would say, the ones that are not specializing and are not interns?
Okay.
What are the numbers?
Very few. I know for sure that if you go to acute care unit now in Mulago, there is one medical officer, one that I know who works there. No, on the outpatient department, for the pediatrics. Right now, there is one doctor who's called a medical officer.
How many are they supposed to be?
Wow. I don't know what the establishment, at least I think in
you're
okay, I would think if I was in charge of that place, I would think at least 4 or 5 medical officers would be on that ward, because it's a very busy ward.
It's a very busy ward.
The outpatient acute care unit, and there's one established medical officer. But there are also consultants on there.
Just a moment.
There are pediatricians, consultants who are in charge of those people. Those ones, maybe there are 2 or 3, I don't know, different wards. But if anybody actually walked into any ward in Mulago now, they would find that there are definitely not enough doctors.
Please.
Yeah, just the wage. The human resource capacity of Mulago is, as they have been reporting to us, is not that bad. They have the consultants, but of course that is the old structure. The old structure they are not, but there is a new structure now. Mulago now has advanced, and they need super specialists, and they don't have many. For example, they don't have so many cardiothoracic surgeons, they don't have so many cardiologists. You find the Heart Institute is run by like 10 cardiologists, Cancer Institute run by like 15 oncologists, and that's so small. But if you come...
When you speak about 15, 10,
Yeah,
so there was a time last year when, for example, oncologists were not more than 15 in the country.
Yes, yes, and most of them are in Mulago here.
Yeah, because we have one cancer
because we have
institute.
one Uganda Institute. So what I'm saying, the structure of Mulago is not that bad. But I want to bring in the factor you have been talking about. What we are talking about is that the intern and the SHO do the dirty work. You are not going to be telling a consultant to run to pick blood for the patient. You are not going to tell the consultant to come and go and pick IV fluids from the store to come and put on the patient. You are not going to be telling the consultant to lift the patient and put the patient on the bed. You are not going to tell the consultant to stay overnight looking after the patient who is critical. The consultant will prescribe, but you not sit in the ward. So this is the context of interns and SHOs. But at the same time, we are a little bit worried because and I'm talking this really as a doctor, but also as a policy maker. We increase the salary of doctors, and we fought that it be increased. But sometimes we don't see that the output has necessarily increased, and that's the question I wanted to answer. Where are the senior doctors?
Yeah,
sometimes,
doctors,
and like in all sectors we have seen, you find the people are non-existent. They are paid, but the output is still the same. So the question is now, if you increase the salaries of doctors and other people, you must follow it with monitoring and evaluation and make sure that their contracts and they are not permanent and pensionable. They work. If they don't work, they should leave, and others who can work take over.
Isn't that a recipe for crisis? How can doctors of a country not be pensionable?
Well, that's the debate, and that can be debated. Okay. At higher level, for me, I think people should be given a contract.
Medical workers should be contract workers.
Yes, yes. From consultant above, you given a contract for 1 year, and you are given outputs, what you can achieve. If you don't achieve, they warn you. If you can't, then others come in. Because then in any case, we can have as many people as possible. Because we have the doctors, we have the nurses, we have people.
What can work for us?
What can work for?
Yes. For Uganda.
Money increased and wage must be followed with monitoring and evaluation and very, very good supervision to make sure people do the work they are supposed to do.
What can work for Ugandans? Thank you very much, Dr. Kamara. What can work for Ugandans, I believe, is just get these junior doctors and the SHOs back into the public service. Yes. Because these are energetic, happy, and wise, brilliant, our best. And here we are tossing them around, wondering what they are. They are beautiful and wonderful and are willing to work. Get them, and fine enough, they are in kind of, they kind of need us, so they need a license. So they work, give them money for a year. That's what they used to do when we were still interns. As soon as I finished medical school, I was a public servant.
Your money for the year is...
Yeah, get them into the service for this 1 year. Pay their internship salary and let them go. After 1 year, they will go and do their own work, and they've given us the best. Imagine a fresh young graduate, eager to learn, is working for us at a very low pay. Because we are going to be giving them about 2.5. That's not a lot of money for someone working 18 hours, 18 to 24 hours with their brilliant brains. Even the SHOs, get them on board, pay them. And these are specialists. These are the people who do the cesarean sections under management. Pay them.
All right, we shall be transitioning very quickly to our very own Stephen Mbide, who is in Ntinda ahead of the World Malaria Day commemoration. But very briefly, I will give each of you 60 broadcasting seconds to wrap this up, because this debate could go on for a whole day.
I know.
Yeah, please, prompt.
Yeah, thank you so much. And what we've been talking about is the health system and its financing, basically. And we've seen that the financing from government is still very low and should increase. However, most of the countries which have dealt and survived this low financing are into insurance. And we shall not settle until the national health insurance bill is discussed and the act and the act passed, because we are lagging in East Africa. We are behind. Tanzania, we started discussing this before Tanzania. We started discussing this before Rwanda. We started discussing before. They came, put everything in practice, and they are much ahead of us. They are so much ahead of us now. We must now start thinking national health insurance. Before that,
wrap this up. We
may not sort our health financing, but we shall have gone somewhere.
Right.
Thank you.
Okay, thank you very much. Thank you very much. My quick few words are these. Number one, we are failing to plan. Government is failing to plan for our beautiful, wonderful, brilliant young doctors who want to work for us. Let's plan for them. Let's make sure that they are put in place and put in sites of working so that they can work. But the source of all this, one of the problems is that we are not regulating their entry. Let's regulate their entry so that we get only the best coming in. And then those that are coming in should be the best to come into government. Let's send them out, let them work for us, and let us pay them. You cannot have somebody working as a slave. Yeah.
Okay. Thank you very much, Edith Naku, President of the Uganda Medical Association. Thank you too, Honorable Dr. Nicholas Kamara, MP for Kabale Municipality, for the very insightful perspective on health financing. I can assure you this discussion should be revisited one of these days, including health insurance. But one thing I picked week is that if you fail to plan, you are planning to fail. Now, let's go to Stephen Mbide, who is in Ntinda, where commemorations or, well, celebrations, some people love to call it that, but we should stay to commemorations of World Malaria Day are. A very good morning once again, Stephen Mbide. How are you?
Yep. Yes, good morning to you, Chris. You know, there is a team that is here in Ntinda, but the main commemoration is in Uganda. And we are talking about time to deliver zero malaria, invest, innovate, implement. And this is a theme for today's World Malaria Day. Of course, malaria remains the leading killer disease in Uganda, in Africa, and in many parts of the world, and this is why there is need to focus on malaria. And today I'm going to be speaking to Tony Luyimbazi. He's the Executive Secretary, also the coordinator for the country coordinating mechanism for the Global Fund. Good morning to you, and thank you for putting up the effort.
Thank you so much. Good morning, and thanks for having me this morning.
All right, let's begin with talking about this disease. It's a burden to many people, especially those in rural areas. Malaria, how bad is the situation so far?
The malaria situation is not so good in some parts of the country. We've seen upsurges in this country, and of course an increase in deaths in some parts of the country, especially among the children under 5. So it raises concern not only to us as the country coordinating mechanism, to the main development partners, but also to Ugandans. Okay, so it's an issue of concern that we must get interested in as a country.
As the country coordinating mechanism, one would want to understand your effort towards the fighting this disease. What have you done so far that one should be interested in, knowing that yes, we are doing something in trying to bring down the numbers of malaria, especially in pregnant mothers, but also in children?
Thanks so much. So the country coordinating mechanism is a partnership between government of Uganda, the civil society organizations, and development partners to fight HIV, TB, and malaria in this country. Taking it down to malaria, the Global Fund, through the CCM, has invested over $263 million in the current funding cycle that is running between January 2021 and ending December 2023. And of course, the Global Fund has also made a commitment already to continue supporting this country in the fight against malaria and the other diseases, and a commitment of over $267 million has been committed to support Uganda again in the fight from next year, 2024 to 2026. So that is quite significant, and Ugandans out there should be interested in appreciating where we are.
You know, when you talk about Global Fund, money comes here, you're talking about $260 million. What exactly is this money going to be doing in the fight against malaria?
Yes, so these investments are tagged specifically to the following interventions. One, we have what we call the mass distribution of the mosquito nets. Of course, many Ugandans out there in the different parts of this country have received mosquito nets from government of Uganda. That is partly a contribution of the Global Fund. Okay, there is also what we call indoor residue spraying, where in some parts of the country we go ahead also to spray particular, homesteads or households where people stay, especially in the West Nile region in this country. But we also are supporting the malaria testing kits, especially those used by the VHTs at community level in the villages. We also support the malaria medicines and treatment. So when someone tests positive for malaria, they're expected to be put on treatment. So again, that is part of the contribution of the Global Fund.
As you invest these monies, but you also have to know that we are dealing with a big challenge. We are now having mosquitoes that are insecticide resistant. This is a big challenge for the efforts of fighting malaria. How can we deal with this, especially at local governments, these districts, the local councils, the village health teams? How can we deal with this? Because it also has to come from the families.
Sure, a very important one there. So much as we've done significant investments in the fight against malaria, but the communities and people out there must get interested in this. Why? Because we can't win the fight alone. without the involvement of the communities. What we've seen just last week when we were doing our joint oversight visit with the board, we've realized that actually there is a low risk perception when it comes to malaria at community level. So someone feels sick, but they don't take it seriously until when they are put down completely, and they seek treatment when it's quite late in the facilities. Yeah, so again, communities must get interested to ensure that at least they build on innovations. Okay, we know right now that, of course, even the mosquito is changing behavior. Previously, we used to know that mosquitoes bite at night or maybe after 6, after 7. But right now, we know that also mosquitoes can bite you before you enter your bed to cover yourself with a mosquito net. So there is need to also do a lot of behavior and social communication to ensure that we create more awareness at community level, but also the communities must be committed and willing to change part of their behaviors to ensure that we win the fight.
Okay, these collaborations are one from your side as CCM, the country coordinating mechanism for the Global Fund, partnering with the government, especially with the Ministry of Health, Ministry of Education, and other line ministries. This coordination, how far can it go when we know that there is also abuse of funds? Previously, we saw what happened to your fund, the Global Fund. Yes, I know you are doing great work on coordinating and monitoring what's on the ground, but dealing with the issue of abuse, you invest these monies or you track these monies, but again, you may find that on the ground, in health facilities or wherever, these funds may not go to the proper use. How can you be able to track and make sure that, yes, there's something that is on the ground?
Yeah, thanks. So what we do is at 2 levels. At national level, the principal recipients, TASO and the Ministry of Finance and Health, they report back to the CCM board on a quarterly basis as part of the oversight function to ensure that the resources that have been disbursed to these 2 entities are well utilized. So that is one part of the accountability mechanism. The other part of the accountability mechanism is also at community level, district level to start with. So Ministry of Health also disburses some money to the district local governments managed by the DHOs. But Ministry of Health this time what they do is to ensure that they provide guidelines on how that Global Fund grant should be used and must be used. So that is critical for members to know. But also those grants are always disbursed against an agreed upon work plan with specific activities on what those grants are supposed to do. Okay, so now the picture is quite clear that even when money is disbursed to the districts, they know what that money is supposed to be used for and how it should be used. So that is the other level of accountability. Now, what we request communities to do at community level, you know, in your village, away from the facility, away from the village, just to ensure that also community members get interested to participate in community-led monitoring mechanisms. And we have structures through which the community members can report back on the utilization of the different interventions that we do at community level. Are they working? Are they not working? What else should we do? So through that reporting mechanism, we engage and ensure that we take feedback from the communities and also to ensure that we redesign our programming accordingly.
Does this mean that there are ongoing studies that are being done to point to this direction of trying to combat or even fight malaria, but also control its spread, especially amongst the young ones? Are there studies that you are part of?
Yes, so there are ongoing studies that the Ministry of Health is doing together with WHO to ensure that at least we understand, especially the current scenario, when we talk about the changes in behavior of the vector, or the mosquito, what is changing, but also trying to understand where we are doing indoor residue spraying. Is there an issue with the chemicals that we are using in terms of effectiveness? So there are quite many ongoing studies, and at the right time, definitely, we'll get you informed about the findings and the results. But most importantly, they are aimed at informing our programming to ensure that we respond to these needs.
Okay, you spoke about the outreach that you've been doing in different districts, but I also want you to speak to these local government leaders, because I know at every village there is a village health team. At every district there is a task team that is supposed to do health monitoring and investment. What's their responsibility in the fight against malaria, especially now that we are commemorating this World Malaria Day?
Yes, so these district health structures, the health teams, the VHTs, and many others, we know they play a critical role. But in the districts that we visited Kamwenge, we visited Ntoroko districts, the other team visited Dokolo and Alebtongo districts. At least we've seen in the districts where we visited that the district leadership is now very keen to rejuvenate and strengthen further these task teams focused on malaria, to ensure that at least the interventions that we do at community level are more effective in terms of utilization, but also spread out, and also ensure that they are able to identify any issues within their districts and report back and discuss them even at district level during their periodic review meetings, monthly but also quarterly, to ensure that those issues are actually reported through the systems and structures back to Ministry of Health and to the partners. Yes. I call upon all Ugandans, especially at community level, to get interested. We can't win this fight alone as partners, as Global Fund. It takes all of us, and the theme is getting back on track to end malaria by 2030.
Thank you so much, Tony Luyimbazi. He is the Executive Secretary and also the Coordinator of Country Coordinating Mechanisms for the Global Fund here in Uganda. Stephen Mbido Professor Chibuga been speaking to him about this day, which is World Malaria Day, and what you and me can do in fighting malaria, which is the leading cause of leading killer disease in Uganda. Stephen Mbide, Professor Chibuga, I have to hand you back to studio, but I have to also remind KCCA that along the Winton Road there is a tree that fell on the road, that is the Winton Road, but also in Nankulabye from Mengo, that Balintuma Road, there is also another tree that fell, causing some traffic congestion there. Stephen Mbide, Professor Chibuga,